I hope you had a great time in your breakout sessions. I've been hearing some glowing reviews. So for those of you just joining us that weren't at the keynote, I'm Sonia Hauser. I'm the chair of the Russell Sage Nutrition Science Department. Welcome. We're glad you're here. So just a reminder, you can, if you have questions, we have a lot of questions already. I think we might be full, but if you have some burning questions that come up, you can write them on the 3x5 cards that are on your table and put them in the basket down here. We'll try to get to as many as possible. So thank you again for joining us. Thank you for those of you joining us on the live stream. We appreciate you being here as well. So at this time, I'd like to welcome Russell Sage College President, Dr. Matthew Shaftel, to say a few words to get us started.
Well, good afternoon, everyone. Just looking around this room, I feel two things simultaneously: genuinely inspired and maybe just a little humbled. Because today we're tackling a topic that has been underserved, under-researched, and frankly, under-discussed for too long. And you all showed up for it right here at Russell Sage, and that says everything. I couldn't be prouder. So we're here to talk about menopause and women's midlife health at lunch on purpose. I'd call that progress for sure. With brownies. But here's what strikes me as both very contemporary and also very familiar about the moment. Contemporary because the science is evolving rapidly and the clinical conversation is finally catching up. And familiar because gathering to advance the health and well-being of women is exactly what Russell Sage was built to do 109 years ago. Margaret Olivia Slocum Sage didn't found this institution so women could sit quietly on the sidelines of their own health. She imagined a place that would educate and empower women to lead, to contribute, and to shape the world around them. And today is simply a direct continuation of her legacy. Only now we have better data, better tools, and thankfully, a much more candid vocabulary. So what makes today especially meaningful is not just what we're discussing, but how we're discussing it. The conversations in this room and in the conversations that are happening around campus today span nutrition, physical therapy, psychology, pharmacy, and public health, because no single discipline has the whole picture. This is truly interdisciplinary work at its best, changing our community for the better. I also want to acknowledge something quietly remarkable happening in the room: the partnership between Russell Sage and Albany College of Pharmacy and Health Sciences. That partnership isn't just aspirational, it's already real. More than a year before our formal merger, faculty are already working side by side, learning from each other, and building something better together. That's not just a merger on paper, that's a relationship in practice. And this community, from students just starting out to seasoned clinicians to public health leaders to community members who simply want to understand their own health better, this is how progress happens. All of you in the same room taking this very seriously. We're grateful to so many partners who make this possible. CDPHP, we couldn't do this without you. Our Women's Institute, Thrive, our alumni associations, our colleagues at ACPHS, our local news stations, for helping carry this conversation beyond these walls. At its heart, today is about knowledge, but it's also about dignity, about ensuring that women's health at every stage of life is understood, supported, and never again treated as an afterthought. Thank you for being part of this work. Now, let's get this conversation started. Thank you.
All right, thank you, President Shaftel. So we wanted to sort of pause in the middle of our programming today to really allow for this interdisciplinary discussion. So our panelists, if you'd like to come and join us. So both for menopause and for GLP-1 medications, right? Because this is as much a societal conversation right now as it is a medical one, right? And it's shaped by access, by equity, by media narratives, unfortunately, and by patient experiences. And all of that is what we do here at Russell Sage in our health science programs, training the next generation of practitioners and healthcare providers. So this is a really important conversation to have. So I'd like to introduce our expert panel. All right, so representing our public health perspective, very important, we're honored to have Dr. Elizabeth Whalen here. Dr. Whalen is the medical director of the Office of Public Health at the New York State Department of Health. She has over 30 years experience in medicine, including work in clinical medicine, managed care, public health, preventive medicine, lifestyle medicine. Dr. Whalen completed her medical training at National University of Ireland, Galway, residency, including chief medical residency in internal medicine at Albany Medical Center. She obtained a master's in public health at the State University of New York at Albany, and has achieved board certification in internal medicine, public health, preventive medicine, and is a diplomat of the American College of Lifestyle Medicine. Dr. Whalen is passionate about advancing the tenets of lifestyle medicine with a focus on health equity and reduction in health disparities at the population health level. Welcome. Representing the clinical perspective, welcome back, Dr. Soa. She's our keynote speaker this morning, and she's agreed to join our panel discussion as well. She's, again, a dual board-certified physician in internal medicine and obesity medicine, author of the best-selling book, The Ozempic Revolution, founder of SoWell, the first doctor-developed wellness brand created specifically for GLP-1 users. And representing our food and nutrition perspective, near and dear to our hearts, we have Caitlin Loesch. Caitlin is a dedicated registered dietitian specializing in nutrition, disease prevention, weight management, and gastrointestinal health. She's a Bachelor of Science from Syracuse University, a master's degree in applied nutrition from Russell Sage College, and she's an Academy of Nutrition and Dietetics member. Caitlin has extensive education and training that uniquely positions her to support patients in the capital region of New York. She emphasizes individualized patient care, designing tailored nutrition plans to empower patients to reach sustainable, achievable health outcomes. Guided by the belief that the greatest wealth is health, Caitlin prioritizes a personalized approach that aligns with each patient's unique needs, lifestyle, and goals. Welcome, Caitlin. Representing our pharmaceutical perspective, we have Nicole Lodies. She's a professor of pharmacy and practice and an adjunct associate professor at Albany Medical College. Her primary research activities and interests focus on tobacco cessation and hormonal reproductive sexual health related issues, with an emphasis on the use of over-the-counter medications in obstetric populations. She also focuses on implications of tobacco cessation, counseling from a patient and pharmacist perspective, addressing curricular gaps to better prepare student pharmacists, and the public health importance of tobacco cessation, education in addition to ongoing educational research. Welcome. Jane Rudenberg, she's a nurse practitioner here at Russell Sage Wellness Center in Troy, and she has a side business supporting women in perimenopause and menopause, very important and needed. Previously, she worked at a clinic focused on women's health and menopause. So Jane notes that back in 2002, the Women's Health Initiative study results curtailed hormone replacement therapy use. Women became sweaty, cranky, and unhappy. Jane is glad, she notes, that HRT has been reinstated and that menopause is a hot topic. Indeed. All right. So to set the stage for our discussion, I'm just going to. So we learned that GLP-1 medications, they're not just weight loss drugs, right? They are metabolic therapies, and they have far-reaching implications for chronic disease prevention as well as weight management. So for perimenopause and menopausal women in particular, these therapies intersect with this uniquely vulnerable phase of life. So it's marked by hormonal changes, shifting body composition, and rising cardiometabolic risk. So we know all of this to be true. So when we first proposed this conference, almost a year ago now, the initial reaction was, well, do you want to talk about menopause or do you want to talk about GLP-1 drugs, right? So I think we have been educated now. We know that those two things dramatically intersect, right? And talking about where they intersect and how they intersect is an important conversation to have. So Dr. Shoa shared that the average weight gain and the perimenopausal phase, which can range from a decade or more, right, is 1.5 pounds per year. And so that is important and something to address, but we also want to look at what are the other changes happening. So to some degree, weight gain is associated with aging in general, right? But as these dramatic hormonal shifts happen in perimenopause, we have dramatic shifts in body composition, right? And not in a positive direction, right? So we have increases in central adiposity, visceral fat, and we have dramatic decreases in muscle mass. And so those of you who were in Dr. Turtelot's session this morning, you learned about how to counter that, so thank you, Dr. Turtelot. We also have, dramatically increased risk of disease. So declines in cardiometabolic health are well documented, increasing risk of other conditions, including mental health disorders. As Dr. Krosick, if you were in his session, he addressed that. And then also chronic inflammation and even gut dysbiosis. So if you were in our culinary nutrition session, you heard all about that. Lots of biochemistry in that session, right? And of course, pelvic floor disorders and nervous system dysregulation are very much intertwined in all of this. So if you were at our yoga breakout session and nervous system regulation session, you heard about that. So we chose these topics on purpose. There was a plan here. I'd like to kind of shift to each of our panelists is going to have an opportunity to say a few words, and then we will transition to questions from the audience. So we'd like to cover this, just the kind of bigger picture societal perspective of these. So we're going to address hopefully ethical concerns, economic impacts, adherence and complications, long-term health impacts, implications for interdisciplinary teams is particularly relevant today, and then just for fun predictions of what we think is going to happen next. So if it's okay with you, I'll advance the slides and then speak from the, your turn? Is that okay? Yeah. Do you have your microphone?
Yeah.
Okay.
I can do it.
Okay.
Hi, everybody. I'm so glad to be here this afternoon to see all of you and to hear about how well this was put together, because it really sounds like there is a very holistic approach to how we address health concerns and improvement in health during this very critical point in a woman's life. So I just want to say thank you. I'm very happy to be part of this. I'm here from the public health perspective, and public health, all of you are probably aware of public health and its role in the recent COVID pandemic, but it is much broader than that. Public health is population health. So we look at how not only communicable disease, but chronic disease affects the public, how we are looking at trends as we move through time, and how we can impact health from a policy, systems, and environmental level. So it's really broader than looking at how we take care of patients, which is, I've been in clinical medicine as well. This is taking care of populations of health and really looking at the root causes. What are the root causes of health problems, and particularly health disparities, because public health is also looking at health equity and making sure that across populations people have optimal opportunities to achieve their best personal health. So when we talk about GLP-1s, I just wanted to level set with a few definitions. And obesity, as you know, is usually defined as a BMI of above 30. BMI is not a perfect metric. I think it's very important that we get that out there right away, but it's easy for people and clinicians to utilize. It is not the full story. It does not necessarily give us body fat percentages or talk about the visceral fat percentage, but it is what is commonly used to talk about risks that are associated with increased body weight. So that's the first thing. I wanted to kind of just reference a little bit about what the data is showing us in New York State. So, if you look at obesity and diabetes, this is really talked about as a dual epidemic. We've seen incredible increases in both obesity and type 2 diabetes in particular over time since the 90s, and it is only increasing. So if you look at obesity as a driver for diabetes, it's linked to 35 to 53% of new diabetes cases in the United States annually. And as you see, as you move from neither overweight nor obese to obese, your risk increases. And obesity is just one disease that we know, or diabetes is one disease that we know that it's associated with obesity. It's also correlated with cardiovascular disease, arthritis, many types of cancer. 58% of adults that have obesity also have hypertension. So there's a tremendous amount of health implications and a reason for us to pay attention to this and to look at it over time. Some really boring graphs, which you do as you are in public health, is to look at, what are the rates of obesity and the prevalence of obesity in this graph in New York compared to the United States. Just going to show you that. Again, this is from 2015 to 2024. If we were looking at a graph from 1990, it would be a much more dramatic increase. And then going to the next one, looking at New Yorkers and the prevalence of overweight and obesity is, again, obesity is increasing and overweight is increasing as well. So just to let you know where we are, 35% of New Yorkers are overweight as of 2024, and 29% are obese. So this is a significant public health problem. It is something that we need to look at from a population health level and really look at the root causes and see how we can address that. So this is not only about looking at treatment, it is looking about how we create environments that we can actually prevent this from happening in. And that's a very kind of complicated discussion. Next slide really just shows how GLP receptor agonists have been prescribed. And we've seen, a really steep rise in prescription of these medications over time. And in fact, I think, according to an article in the Journal of the American Medical Association, total spending on GLP-1s increased 500% from 2018 to 2023. So this went from $13.7 billion to $71.7 billion. So it's costly. And of course, the chronic diseases that are associated with being overweight and obesity are also costly. So it's incredibly important that we look at this from a policy, systems, and environmental health level. Obesity itself accounts for nearly $173 billion in medical expenditures, and that's a statistic from 2019. That's an old statistic, so it's much more than that. When we look at the implications and the impact on health systems, it is obvious how these statistics translate to impact across health systems and across the span of life, across the span of health in the country. So obesity is, I know it was discussed a lot this morning. It's really, there are a lot of complex environmental and genetic factors, but it is largely preventable. But we have a problem in the United States, and this problem is a major problem in most first world countries, and that's that we live in an obesogenic environment. When you look at the amount of processed foods that we know are associated with poor health outcomes, negative nutrition implications, 55% of the American diet is currently ultra-processed foods. We have moved away from whole foods. We have moved away from foods that nourish us, that keep BMIs relatively stable. And ultra-processed foods, and the food industry in particular, is really doing a number on the American diet. So, it is very hard for people to avoid foods like this. So when you look at policy systems and environmental health changes that can occur, there's a tremendous amount of work that needs to be done from an educational perspective, from a policy perspective, and from how we use foods in the environments that we are in to be able to work against this tide. Big food industry has taken a lot of their playbook from big tobacco. We know that ultra-processed foods are designed to make them more palatable. They are hyper-palatable foods. And so people are pretty powerless against them unless they have this awareness and knowledge. So really working hand in hand with partners in education, in healthcare, improving that education at all phases of life is going to be very important in addressing the root causes of this going forward. So that's a basic public health overview.
Thank you so much, Dr. Whalen. Dr. Soa, because we can't get enough, can you give us some clinical considerations? Anything else you want to mention?
Aren't you guys sick of me? So just to take Dr. Whalen's point, I'm gonna just go off what you said, because I've really run out of things to say. No. Can you believe it? But big food industry is actually trying to actively engineer foods to counterbalance the effect of GLP-1s. That's how evil they are. So they're trying to figure out ways around the fact that there's decreased food noise and cravings for hyperpalatable foods. That should be illegal. And to the point of we're talking about the expense and the use and the cost right now. And with that, I often get pushback that aren't we just putting a Band-Aid on a problem, because treating the obesity is not necessarily getting to the root cause. I would say the counter to that is treating the obesity is helping us get to the root cause of so much future disease. We absolutely need to take this time, this revolutionary time in medicine where we have the advent of GLP-1 medications, to take a big step back from a policy level and use this as an opportunity to slow down the prevention, the progress of disease, to prevent disease, but also to go back, because it's not my goal, even though I have a whole career built around GLP-1s. It is not my goal that every single person is on a GLP-1. I hope that for my children and my grandchildren, we are able to use this moment in time to start changing our epigenetics back. We talked a little bit about that earlier, how epigenetics are the layer on top of genes. And we need to figure out how to change everything around us, our food sources, our air quality, our water quality, how we feed our children in schools, how we move around our communities. One of the wildest things with GLP-1s is that people's whole lives change. And I don't just mean they're eating healthier. They are like craving broccoli for the first time in their life, and they're shopping differently at the grocery store. And it's not even because I told them to. I mean, I did tell them to, but they innately have a different desire. And so that trickles down into their families, and then their children are eating better. And then they want to move their bodies more. So now they're going to take a walk around the park with their kids. And then they start to notice, oh, we don't actually have great trails here. Maybe I should work with my local town to do that. And then maybe we start to look big, but also small. So it starts in our homes, and then it moves out to our communities. And I think that that's the most remarkable thing about this revolution right now with medication. It's really a new advent in medicine. And so, try to fight against that when you hear that sentiment, that it's just putting a Band-Aid on the problem. No, it's going to allow us, but we need to put in the work on these laws, and we need to hold our government and industry to standards that allow us to go back and fix it. So just a little add-on to that.
Yes, thank you. Caitlin, we would love your perspective on the food and nutrition considerations here.
Yes, definitely. So as we know, and as everyone has talked about today, GLPs have really changed how we look at weight management and we look at metabolic care, menopause, and that definitely affects our nutrition. The medications can be effective, but they don't take away, our nutrition and behavioral changes. If anything, it makes it more important during that time. As previously probably mentioned in the keynote, GLPs can reduce appetite. They can slow down your stomach emptying. So some of the times, a lot of individuals, they notice that their intake is lower. They're not eating as much throughout the day, and without proper guidance, that can really affect the quality of their food or can cause nutrition complications down the road too. So we want to try to use this medication not as a Band-Aid, like you mentioned, but using it to amplify those changes and really focus on the quality of our lifestyle and our modifications and our eating habits. And dietitians play a big role in that. We have definitely formed how we go about counseling with individuals on GLPs now. We are no longer just supporting weight loss. We are also trying to help prevent loss of lean body mass. We're trying to help prevent nutrition deficiencies. We're also trying to reframe people's eating habits to accommodate some of these altered appetites or hunger cues. We collaborate with everybody within the medical field as well. You know, we're always communicating with physicians and behavioral health specialists, with pharmacists, to ensure that these patients, specifically on these medications, are receiving the proper care that they need. We are called upon a lot in these circumstances. We help build conversations about medication titration. We help kind of design individual eating strategies too, if they are experiencing certain complications. And we help the patients understand what it can look like to eat well while on these medications that have maybe altered how they feel throughout the day. And with that being said, because they do alter your appetite, they reduce your intake, there are potential possibilities of complications. Some of the most common ones that we see is inadequate protein intake, which can potentially cause loss of muscle mass. So we always focus on trying to ensure that patients are getting in adequate protein. Even so, with that, it could lead to micronutrient gaps because of less intake, and even more specifically iron and B12 deficiencies, because a lot of them are found in those protein-based foods that we are not taking in as much of. Sometimes the medications cause GI symptoms like nausea or constipation, which again is going to affect individuals' intakes and the food variety that they're consuming. So that could lead to further deficiencies. And then hydration is a big one as well that we see. It's often overlooked because we're not always acknowledging that we are intaking less fluid when we're also intaking less food too. So those are common things that we see overall. So to kind of take away from all of that, GLPs are not the Band-Aid, they're not the end of nutrition conversations. If anything, they're the beginning of them. We want to be supportive in the sense of helping with weight loss, but ensure that we're doing it in a safe and sustainable way for long term.
Yes. Thank you so much, Caitlin. This is such an interdisciplinary topic that we have both our pharmacist and our nurse practitioner tag teaming on our pharmaceutical considerations.
So first and foremost, I want to kind of echo the previous comments of this is a wonderful format and dialogue on such an important topic, and certainly kind of highlighting the team approach is in a nutshell. We highlighted this in the beginning in our earlier sessions, and it was probably highlighted for all that it is so individualized, but you really do need to pull in all members of the healthcare team in terms of really kind of looking at the patient as a whole. So we're going to kind of break the trend in terms of kind of starting with some of those common questions from a hormonal therapy perspective. Certainly additional considerations were highlighted during our morning session and will come up in the afternoon session. And then we're going to look kind of more from a social media promoted, some of these compounding types of GLP apps and programming and online tools that are out there. So we're going to kind of Jane and I are going to kind of tag team again for this panel piece. I'll kind of give some of my 2 cents for this first slide, and then I'll transition it to my colleague to kind of add on to some of her considerations, and then we'll move to slide number 2. So 2 things that we kind of wanted to highlight that often come up, at least for myself, anecdotally, in terms of common questions on hormone therapy is discontinuing, number 1, and then thinking about duration. How long should I be staying on this? How, is there any guidance? So I'll start with that point number 1 in terms of discontinuing. There's a number of different considerations certainly that come into play. Something that we highlighted a lot for folks that attended the morning session is, again, individualized approach and listening to your body in terms of what your symptoms are. So it's not necessarily something where we're going to be looking at lab values or anything like that. It's how do you feel? Are you still experiencing symptoms? Do we need to still make medication adjustments or otherwise? Or are you thinking, you know what, I feel like I can start to pull back on this. I want to try without the hormone therapy. So how do I go about discontinuing? 2 different common approaches. 1, abrupt cessation, so I'm just going to stop. And on the flip side, tapering. What I would say anecdotally, and usually what tends to be recommended more, is thinking about tapering. You can modify in terms of I'm going to start to reduce the dose, I'm going to increase the frequency between dosing, and then start to think about, how again am I feeling as a patient with my symptoms. So that again is something that we echoed in the morning session is, has the patient, if you're thinking, you know what, I am still not, I'm starting to pull back and I'm noticing a recurrence, or I'm noticing that I'm not feeling quite as good as I did before when I was on the higher dose or when I was taking this more often. 1 point, kind of a take-home point of a word that we highlighted during the morning session was advocate. Advocate for yourself. Pull in additional members, again, of that healthcare team of saying, I don't know if this is working. But those are typically kind of the 2 approaches. And again, kind of more leaning towards what more providers typically lean into is that tapering approach. So again, you can reduce the dose, you can modify the frequency, you could do both at the same time as well. That's going to be more a patient and provider decision. So it's that shared discussion and shared decision making. What I will say from kind of where the data is there's definitely a question that always comes up of, will I have greater symptom recurrence if I'm using abrupt cessation compared to tapering? There really hasn't been any consistent difference between those 2. So having said that, symptom recurrence may certainly arise, and then you kind of reset the clock and say, okay, what's going on? Are we going back on this? How long has it been? And then really kind of restarting kind of next steps. The second piece, and then I'll kind of toss it to my colleague, is duration. As noted on the slide, there is no clear consensus. There's no clear guidelines in terms of how long. So one of the big things that we talked about within our morning session is when you're thinking about hormone therapy, again, individualize, listening to your patients. But typically we think about 2 different core, these are not all inclusive, but 2 different core components is our younger patients and thinking about individuals that are within that 10 years of menopausal onset. That tends to be more favorable, broad considerations when you think about the use of hormone therapy. But how long to keep them on that again is going to be not necessarily a black and white answer. It's going to be very gray. It's going to be that consideration of let's pull back, let's come off of it, try the discontinuation. If we need to maybe think about adding back on, that may be an option as well. But in a nutshell, and most of the guidelines to date do not. Early on, years past, they had some initial guidance of saying, well, once it hits 3 years, 4 years, 5 years, maybe start to kind of pull back and modify or think about discontinuation and pulling them off in terms of hormone therapy. But I think where we are more contemporary now is, again, let's make it individual. What is going on, and then let's reassess accordingly. So I'm going to toss it to my colleague to see if you have any other thoughts, and then we'll switch to the next slide.
I just kind of want to say, yeah, what she said. But, yeah, for sure, in terms of the guidelines say, don't do it after 60. But if you are a person who's been doing your menopausal hormonal therapy and you feel good and then you stop it and you start getting symptoms, it's an individual concern. You talk about the risks, you talk about the benefits, and you let the patient decide what's more important to them? Is it more important to avoid any risks? And, go through those specifically. Or do I really like to sleep at night? So, if it's like, I really would like to sleep at night and I want to keep going on this, then it's that person's choice of what they want to do within, safe guidelines. Because each person knows what they really want and what is important to them. And I think that's been the hard part of menopause treatment forever and ever, at least since the Women's Health Initiative, that, traditionally women haven't really been listened to, and we're hysterical and anxious. But our symptoms are real across the board, and it's more and more becoming spoken of that we need to actually listen to people and what they say. And there are so many symptoms other than hot flashes and vaginal symptoms. We were talking about all sorts of crazy things in our thing earlier that come up. So it's important to listen to each patient and know that these therapies can actually help so many more symptoms than just the ones that have been studied. I know it sounds terrible, but there's a whole spectrum of symptoms for your patients. And so you want to treat that person, their whole spectrum, not just the things that have so far gotten researched. Hopefully everything will get researched and is in the process of it. But so it's individualized, and you talk to the patient and you share what the risks are and help them decide what they would prefer to do. Okay? Another slide.
We've gotten a lot of questions about compounding and all the different avenues you can get GLP-1 medications. Could you touch on that a little bit?
I can kind of highlight this in one scenario, one word. No, don't do the compounding of some of these products. But certainly it's much more complex than that. So I will kind of pull back. It's definitely one of those things that I would love to, if I may, just to kind of get a show of hands of how many folks have gotten questions about some of these types of online apps, Roe, him, hers, have gotten questions as clinicians. Just show of hands, if you so choose. All right, so a couple. It's definitely something that I think individuals, I am hearing a lot more questions about that. So a couple of things just to provide some background for those that may or may not be familiar with some of these different types of, and these are 2 examples of many online types of programs. So Roe, hers, just to give some examples, but these are online virtual resources, networks in terms of assessing or in terms of accessing some of these GLP types of medications. And what a lot of them have done, so it enables you to have, certainly on a pro side, on an advantage side, increase the access if maybe, again, you're maybe not able to get in, or you're in kind of more of an area where it's a little bit farther for you to get access to a provider. Okay, so those are positives. Those are certainly advantages. But on the flip side, it's important to be aware of the types of medications and which ones, has a patient, has a clinician, that if they are utilizing some of these formats, should they be more directed to? So in a nutshell, kind of to my earlier point, my general sentiment from a clinician, from a pharmaceutical perspective, is recommending those FDA-approved options. Some of these sites will highlight custom compounded GLP products in terms of, okay, maybe there's a market shortage or supply shortage, you can get custom compounded products. What I will say is that there has been some highlights, some news releases from the FDA specifically warning against utilizing some of these custom compounded types of products. So I do think it's something that just for clinicians to be aware of, are you kind of, exploring this? So ask a little bit more of those open-ended questions with your patients. Have you heard of some of these sites? What do you know about these sites? It may not necessarily be something that they are generally bringing to you proactively, so certainly encourage that engagement of that dialogue and that conversation. But typically what we recommend kind of from a clinician perspective, again, my own anecdotal perspective, is to stay away from those custom compounded, even if they note it's utilizing FDA-approved ingredients. The FDA really can't confirm that overall safety and efficacy of these custom compounded types of products. So really from a safety perspective, I think it's best to advise patients to utilize, certainly our FDA-approved options for accessibility. With that being said, I would also highlight that, again, some of these sites, our virtual visits, and you may be missing, having that conversation, the importance of having that dialogue and that face-to-face with a clinician in front of you, for them to be able to do additional fact-finding. We talked about that in our morning session, just to make sure, is there other things going on? It's not just here's this magic pill, kind of to all the points that all of these members on the panel have highlighted previously. It's multifactorial, and having that dialogue is incredibly important to make sure that we're having that face-to-face with a clinician. So just my own 2 cents, I would say advocate in terms of that holistic view and really encouraging patients to have kind of that one-on-one conversation, because although there are some advantages of these virtual platforms, we just want to make sure that we're informed and recognize that there are some disadvantages and some potential concerns depending on the types of products. If you're getting an FDA-approved option from these platforms, that's reasonable. But it's the custom compounded that generates some of the concern from a practice perspective. I'll toss it to my colleague.
Actually, I had one more question for you that I thought of. So fun to have pharmacy. So what about the pill? Now they're saying there's GLP-1 pills. Is that actually a thing?
Thank you, Jane, for that question. Yes, and that is actually going to be something, I'm not sure if this is going to come in some of our questions later, but what is coming up and what really, I think, drove a lot of folks, again, from my own kind of anecdotal perspective and just hearing kind of what was in the news, is when there were availability concerns, that's what really prompted lots of folks to look at some of these different types of online platforms. So there is, yes, pill options. That may be something that I'm not sure how, I'm not as familiar of whether or not, platforms such as hers and Rose, whether or not they're promoting some of those. So I'll certainly refer to my colleagues in terms of the pill options. But they may enable some additional access from a cost perspective. Certainly, whether or not the insurance piece certainly plays in mind as well. But I'm going to toss it to you.
I have lots to say about this. Sorry, I'm like waiting to jump in. So high
Please
level.
do. Love that.
No,
yes.
no. So, but high level, the compounds. So I think you all know, compounds pharmacies can be an amazing option. The problem is compounding GLP-1 medications, especially the injectable, is very complicated. Okay. So what they are providing in compounded GLP-1s is not the same as what's happening in an FDA facility. And there are different levels of protection, and some are better than others. It was just Hims and Hers just recently really went head to head with Novo Nordisk and lost, and so they are actually no longer providing compounded medications. And so if patients are on compounds, they might not be getting them even in facilities that are being regulated. A very dangerous thing that I think people should know about is that a lot of these platforms, and they're the seedier ones, but even some of the very good ones, including, and I will call it by name again, MIDI, they are providing medications that are not even FDA approved. So they are saying that they have tirzepatide in a pill. Tirzepatide will never come in a pill. It's not even in pipeline development, so I have no idea what the heck that is. And then you'll see a lot of stories on GLP-3. It's even the wrong name. It really drives me crazy. It's retatrutide or retatrutide. It's in final stages right now. It is close to FDA development. It is going to blow all of the drugs I talked about today out of the water. It is somehow in this country, especially in gyms, but it is not the real version. It is coming in research powder, and then people are reconstituting it on their own. Yeah, right?
My pharmacy flags are going off.
There's so much danger. So we do have oral Wegovy. We've had oral semaglutide for about 10 years, actually. They've now rebranded it for weight loss. It just came out. It was a big fanfare in January. Some of the platforms are offering that, and that's great. The cost, in my opinion, is still high, but there is a better access issue. Yeah. The one pill that everyone should look out for that is not out to market yet is orforglipron. Mm-hmm. That, I think, is going to revolutionize care because of the way we make it. So it is a GLP-1 medication, but it's a non-peptide. So I don't know if I even use this in the lecture today, but people talk about peptides. What does that mean? It just means that it's the way that the proteins are put together, but it's actually kind of complicated to make it in the lab. Yeah. And this is why making compounds is hard. The pill, the non-peptide GLP-1 version of the pill, is going to be very easy to make. and cheaper to make. And they have been very smart in how they've studied it. They've studied it in people who have lost their weight on the injectables and are coming off and put them on the pill. So maintenance will probably start to look like that for a lot of people in clinical practice, and that is a fantastic advancement. So just because you see pill doesn't mean it's bad, but you've got to do, and it's so hard because even here we're clinicians, and how can you stay on top of all of it? You have to do your research. Is this actually legitimate? Some of these, and some people, MIDI too, gosh. This is probably gonna go viral, and they're like, oh, we hate you. But they're like, I saw them offering a drop on your tongue. These drugs are very, very difficult to absorb, and that's why we don't actually have a lot of pills. So like a drop on your tongue is gonna do nothing. So they're selling sometimes products that just don't work either, and sometimes I've had patients who've come on compounded, and they said, I was so sick, it just didn't work. I have no idea what was in that thing that they were injecting, and that's why the
That's
FDA
the
is really
scary
important. So,
Yeah.
thank you. Sorry, but
Oh
there's
my
some real clinical pearls
This
there.
is part of the interdisciplinary. This is what we love. Yes, and
This is why we're here. So this is
absolutely, and this goes back to, I'm just going to follow up on those points to echo all of them. It's so incredibly important, again, to be an advocate for your patient, to be an advocate, and then to reach out and gather a health advocate for yourself. If you are a patient, reaching out to other members of your healthcare team to be like, I'm hearing this. What are you hearing about this product? What's the latest studies? Or reach out to each member of your healthcare team in terms of better informing yourself as a clinician, so you are as well versed as possible to best assist your patient. So I think, thank you for jumping in.
Great, thank you everyone. I'm tempted to just let this go, but we are at our Q&A portion. And so, just Sue, any more? Okay. So do you worry, we're shifting back to the public health kind of perspective here, do you worry about GLP-1s potentially driving an increase in obesity-related health disparities? And this is because since populations with the highest rates of obesity also have the lowest rates of access currently to these medications. And then related to that, it's a two-part question, what are some evidence-based strategies to prevent obesity from starting to begin with on the public health side going forward?
Thank you for those questions. And before I answer them, I just want to make one little comment about the Band-Aid comment, which I didn't say Band-Aid.
No, not you.
But the world, because I think that, you know, when you look at, again, when we talked about the trends of obesity, and we talk about what's happened since 1990, and we talk about this food industry and hyperpalatable foods, et cetera, the people that are landing in this generation right now that are suffering from conditions that are related to overweight and obesity are benefiting greatly from GLP-1s. It is life-changing. So I don't want to seem like I'm in any way not encouraging that. I think it is tremendously important. I think these therapies, the literature that's coming out, day after day after day, we're getting more important health benefits that are coming out from these medications, and they're wonderful medications. But from a public health perspective, we also look at sustainability. So, you know, here we are, we've looked at what has come about, and we talk about what do we want for our children, and do we want that for the next generation as well? So that's where public health problems and solving things from systems perspectives comes in, so that we don't have to have future generations consider with this, or continue with this trajectory. So to your questions about disparity, yes, I do worry significantly that these will increase health disparities. We know in New York State and across the country that our rates for overweight and obesity are much higher in Black and brown populations. We know that there is a higher rate of overweight and obesity in people that are socioeconomically disadvantaged as well. And these are drivers of where people can access care, what medications they have access to. There is even literature that suggests these medications are prescribed less to Black and brown people. So this is incredibly important from a public health perspective. It is something that we have to look at. And again, when you talk about drivers of obesity, those populations are also disadvantaged by the food environments that they live in. They are more likely, if they are living in poverty, to be shopping for food at a dollar store, where really all you can get is ultra-processed foods. There is less availability of fruits and vegetables, of whole foods. There is less ability in terms of time and in terms of hierarchy of needs to take the time to prepare good food. So we need to change this from a systematic perspective. We need to look at, what we're serving in schools, what we're serving in hospitals. There's a tremendous amount of work that's being done in the New York City health and hospital systems right now. What they did was they have made meat the non-default option anymore. So, if you're in the hospital, what would you like, the chicken or the beef, or you have to ask for a vegetarian option. They made the first option now vegetarian. And they have a meat option, so, if you don't want to be vegetarian, you don't have to be. But what they found is 55% of people will order the second time the vegetarian option. They have, in doing this, set a good example for a food environment in a place that's supposed to provide health care. They have decreased their cost of how they are operating in the hospitals for the food systems, and they have a 30% reduction in greenhouse gas emissions because red meat and consumption of red meat is associated with increased greenhouse gas emissions. So there are wins that are happening across the state and across the country. Another thing that is really important is looking at how people are educated and how we provide, and I'm kind of getting into the evidence-based strategies now, how we provide care and across the span of a life. I'm certified in lifestyle medicine, which is a relatively new medical specialty. It is really focused on holistic care and prevention. Plant-forward nutrition is highly advocated for, and as well as physical activity. So many people that live in these disadvantaged environments that we talk about can't really get physical activity because they might be afraid of safety going out their own door. They might not have access to a park. They might not be able to walk or exercise in the communities that they live and serve in. So how are we changing this from a societal perspective? We need to also focus on connection. Relationships between people are incredibly important. And, if you can get into a walking group or be together with people, we talked a little bit about at the table about the importance of group medical visits, how people work better together and achieve goals better when they're doing this in community. We have a substance use problem in the United States as well, and we know that substances can cause people not to be as discerning about what they're eating, so addressing substance use. Sleep is another huge thing that we don't really address in our medical visits, and it's a very important tenet of lifestyle medicine. Getting good sleep powers your body. It helps your body metabolize the food you eat, and it helps you, you don't eat as poorly if you're well rested as you might if you're cranky and haven't slept as much. So there's a tremendous amount of evidence-based work, policy systems and environmental change that can occur, and I think awareness is very important. I know we didn't really talk about the new food pyramid that has come out from Health and Human Services, and there's a lot of controversy about that, and I think there's some good that's come out of it, and there's some bad that's come out of it. The good that's come out of it, I think, is more emphasis on whole foods. I think that, talking about the existence of ultra-processed foods, the negative health implications of ultra-processed foods, the way that we, curtail that industry and that consumption is incredibly important. Where I think they kind of necessarily didn't do a great job was putting, a huge steak and cheese and full-fat dairy at the top, and then say you should have 10% of your dietary intake from saturated fats. Kind of hard to do that, kind of like an oxymoron there. So there is some conversation that's occurring on about that on the national level, and hopefully we'll be able to take the good bits forward and change food environment in places where people live, work, and spend time and receive care in the next coming years.
Thank you so much. All right. So this next question, I think, is for Dr. Soa and Caitlin, both, if you want to tag team. So it has to do with handling the GI side effects. So maybe Dr. Soa, you can speak to dosing strategies if there's GI side effects, and then maybe Caitlin, you can speak to specific nutrition interventions that you would do.
Low and slow. So that should be the mantra with these medications always. And there's actually a lot of confusion out in the community. Wegovy is written, Wegovy is semaglutide, Ozempic. Wegovy is the weight loss version. It is written and approved by the FDA to go up every month until you get to 2.4. 2.4 is the only approved long-term dose of that drug. I get a lot of pushback from insurance companies, even with coverage, that they want me to take a patient up. Why would I take a patient up if the lower doses are working for them? We see the same problem with tirzepatide. There are, if I can do my math, there are 7 doses, and 3 of them are approved for long-term use. So the in-between doses are not, and I can't keep people on them for many months. But to fight side effects, start slow. And we address and educate up top. So this is why I take people in my program, and why I wrote the book was to educate and to say these side effects do not mean that the medication is failing you. They are anticipated, they are normal, and here is how we prevent them, and if they come, this is how we fight them. It's the whole reason that I've dedicated a silly amount of time and money in my life to developing products for GLP-1 users, because out of my practice, I realized I was putting everyone on the same sorts of protocols because they need things outside of the medication to feel well. They all needed electrolytes. They all needed additional protein when they didn't feel like eating. They all need additional fiber. That is the hardest thing for people to get into their diets. You can agree with me. I think it really is. It's so difficult, and especially as you have decreased ability to intake food. And so I think education and just awareness, and then you have to give them a toolkit. If you can't have easy access in your portal when people are experiencing diarrhea, constipation, nausea, then you need to give them a very comprehensive handout. I think I have it on page 126 of my book because it gets referenced to me so often about what you should go pick up at the drugstore to fight the GI side effects. I think the biggest thing, and this is even beyond dosing, is telling people don't ignore things. You know, these headlines that I see, paralyzed stomach, I ended up losing part of my colon, I ended up in the ER, I missed my own wedding. I mean, these are real People headline stories. People headline covers these drugs more than any other news source, I swear. This is when people were really ignoring symptoms. And I think sometimes people just need permission to reach back out to the prescribing clinician to say, hey, you don't have to deal with this on your own, just let me know. And I literally say, I have so many tricks up my sleeve. I say that like 6 times a day. Just let me know what you're feeling, and then I'll tell you how to fix it. And sometimes when it comes to dosing, you actually do need to stop. So, especially in the case of diarrhea, I find that GLP-1s make adult guts more like children guts. So what I mean by that is adults don't vomit that much, and GI diseases are pretty self-limiting, as opposed to children who at like a turn of a hat will get sick and vomit. And I find that when adults are exposed to something, it can stick around a lot longer when they're in GLP-1, and it theoretically makes sense because your gut's moving slower, so maybe the virus is sitting there a little longer. And so what I will have people do is I'll say, okay, let's treat whatever is going on right now. I might give you a little Imodium. We're going to take a very gentle diet, and you're going to hold this medication until you are feeling better. And then, if your symptoms come back after we give you the medication, well, then it's a little bit medication mediated, and we need to pull back. And we need to go back. Maybe it's 1 dose, maybe it's 2 doses, and we need to start again. And generally that technique works, but I think we push up too hard. I think something that's very broken in the medical system right now is there are so few visits to be able to see it in most doctors, and with titration it should be it should be month to month. I don't write people when they're starting medications any refills in my practice because I want to hear from you after the 3rd dose to see what you need for the 5th dose. So it gives me enough time, and that's the instruction in my practice. And that's the kind of frequent check-ins that people should be encouraged to have. Now, you need to protect yourself in practice, though, because that does not also mean an open portal inbox all the time. And if you can prepare enough with kind of preformed questions and give as much advice up front, it will really help you.
And yes, on the nutrition side of it, there's definitely a lot of interventions that can help with some of those GI symptoms. That's definitely where the individualization comes into play. I'll kind of say I also have a lot of tips and tricks up my sleeve, so it's very dependent on, okay, when are these people experiencing these symptoms, how often are they occurring, and maybe we can find a solution for it. With nausea, a lot of the times it's ensuring proper hydration. You know, are we staying hydrated more specifically before we take the injection and even those couple of days afterwards? Are we taking it slow? You know, if we're eating really quickly, a lot of the times that can induce some of the nausea because we have a slowed down digestive system. Food is sitting in our stomach for longer, so a lot of times that can emphasize the nausea. A lot of the times we'll suggest smaller, more frequent meals throughout the day rather than trying to aim for 3 larger meals. Go try to aim for 5 to 6 smaller meals. But always try to pair nutrient-dense foods together when we can, not trying to just eat one food item by itself, but hey, can I get in a little bit of protein and maybe a fruit, a vegetable, a whole grain to also build in a little bit of that fiber too. That also kind of helps with if people experience early satiety, they get full really quickly. If you're able to break it up into small increments throughout the day, a lot of the times we see patients are able to intake more without feeling the need of taking in a large volume at once. Constipation, it is a big common side effect that I see in a lot of patients on GLPs because of low fiber intake. I feel like Americans in general, even outside not on GLP medications, we don't take in enough fiber.
95%.
95%, exactly. So it is always trying to use protein is definitely talked over and over again with GLPs, but also fiber is that second priority. So if we're experiencing constipation, let's get in fiber, let's get in hydration, let's keep our body moving so we can try to keep those bowel movements as regular as possible.
Constipation on these meds also often needs medical intervention. So sometimes it's just over-the-counter remedies, but you have to be very careful about what people use because they can really hurt the gut. But there are actually medications that help with chronic constipation. So that's a screener, and it should be for everybody here. Have you dealt with constipation in your life? Okay, well then we really need to watch this, and we might have to treat this beyond traditional interventions.
Definitely, and that's where the interdisciplinary team definitely comes into play. You know, we're conversating back and forth. They've tried X, Y, Z. This is what's helpful. This is what's not helping, and so we can kind of go tit for tat back and forth. Make sure we're giving them the proper care.
All right, thank you. Okay, I think this next question is for Nicole and Jane. So this has to do with sort of the intersection between hormone replacement therapy and GLP-1 therapy. And so does that, first of all, do they augment each other? And is discontinuation going to look different if they're on a GLP-1?
Do you want me to jump in first? All right. So yes, actually this question, and I guess before I jump into the question, I'm so glad that you guys talked about the low and slow and encouraging, again, clinicians or patients to talk to their clinicians. Going into that question, yes, I mean, certainly I think both of these different medications are going to interplay, but at the same time, you have to still address them somewhat, my own anecdotal perspective, somewhat individualized of what is going on the menopausal side, and then what is going on, again, kind of in terms of your utilization for your GLP. If patients are discontinuing either of these, let's say now I have gotten off, I've done my taper for my hormone therapy, and now I'm noticing symptom reoccurrence, which is very common for many patients. Symptom reoccurrence does happen. So that's where, again, it's having that dialogue, having that conversation back with your clinician. I need to go back on this. And maybe it's utilizing the same form, again, starting with the low and slow, depending on how long it's been. Since you've been discontinued off of that product, you may need to start kind of from scratch at your baseline starting point again, and then kind of modify supply up accordingly. Maybe it's utilizing a different dosage formulation and then kind of adjusting accordingly. And then I would kind of say the same thing in terms of that same theme of if I have now come off of a GLP, and certainly I'll toss it to my colleagues, but first I'll hand it over to my colleague on my left, Jane, for her perspective on that. But if a patient has gone off their GLPs and now they're seeing weight regain, yes, they can certainly restart on these products, but depending on how long it's been, they may need to start at those lower doses before they're starting back on. So it kind of depends that window in terms of discontinuation is also a key factor that certainly plays into that. Thoughts?
You guys have said everything I want to say so beautifully. But yeah, definitely the starting low and going slow. And again, individualized. So if somebody comes in and says, I've got this symptom, this symptom, this symptom, you look at each individual symptom and don't treat everyone who's having perimenopausal or menopausal symptoms the same, because every single person will do it differently, which is kind of, I think, why it's another one of the reasons why it's been undertreated and under-recognized, is because almost everyone presents differently, and there hasn't been that great of training with it. So again, I always go start low, go slow, but also lots of time talking with the patient. I have the great luxury of being able to actually directly converse with patients because I don't have that many, and I work at Sage, and it's a lovely thing. But I love to talk to each person. I love to hear back. And we had several people in our session this morning who felt like they didn't have any way to feed back to their provider, before their 6-month visit. And I would just encourage people, call and tell them what's going on. Call the nurse line. Most practices have a nurse line, and the nurses are really good at the specific problems for those practices. So if they think that there's something that you can do that's easy, they will tell you, and if it needs to go on to the provider, they will help make that happen. So I always sort of encourage people to talk to the nurses because they're in the know about things. But yeah, starting low, going slow, individualized, and lots of listening and finding it funny, because a lot of times it actually is funny.
Thank you. Oh, is that it?
I think I would just, honestly, I'm sitting here thinking how sad it is that some people have 6 months to be able to ask a question. With any of these drugs, it does have to be individualized, and I understand that's coming from a place of privilege in the way that I run my practice, and I hope it is for everyone, but that's how people end up with these terrible headlines and these complications from the drugs, because they're just kind of left to their own devices. And I don't know, we're talking about these online platforms. Some of them aren't. I think virtual care is fantastic. It's asynchronous care where you never have to actually talk to a human being. That is the real problem. And I just had a Instagram video go super, super duper viral because I was talking about a scene from the real secret lives of Mormon wives. That's it. And one of the poor girls with a long history of an eating disorder somehow got her hands on tirzepatide and went down to a BMI of 14, and it's all on camera. And I'm thinking, how did anybody around her let this happen? And there were so many people in my comments just, yeah, my sister did it. She just lied about her intake form.
Or they're utilizing AI to adjust.
Yeah, or they're just like, okay, well, I'll just figure out what my BMI needs to be. I can calculate it. I'm smart enough to do that, and I'll just lie. Because I want what everyone else is talking about. Because what we're talking about today sounds pretty awesome, but this is not for everybody. And it's just sad, and I don't have a total solution for all of it.
Thank you. So we have so many questions, and we're coming up, and we have less than 10 minutes left. So I'm trying to kind of condense them. There's a lot of questions about microdosing, and I feel like that might be opening a can of worms, but there's a lot of questions on it. So maybe this is, so we have that, and then I have a question sort of for the whole panel to address. Do you want to talk that briefly?
Okay. You've already heard me talk a lot, but I got opinions on this one too. What is microdosing? It's not a thing. It's a made-up thing. It's a made-up thing from platforms that are trying to sell people this medication who don't need it. It's those ads that I showed you that were targeting, don't have a BMI, overweight BMI, no problem, we'll help you. Only in very rare scenarios does someone need a sub-therapeutic dose of what is set by the FDA with these medications. And I have done it, so I guess technically that's microdosing. But the way that it's being sold and the way I understand it, it is just a tiny, teeny dose. And at first, when I started hearing this, I kept thinking, I think this is just weight stigma masked. I think this is just people saying, I don't really need the drug, I just need a microdose of the drug. And I'm like, okay, if that makes you feel better, you're just on the starting dose. But no, now it's companies with compounds saying we're gonna be able to give you a personalized dose. And there are a lot of health influencers out there saying it reduces inflammation, it helps me feel better. Well, that's great, but that is not the indication, and we don't have proven benefit yet. I do believe within 10 to 15 years, probably 5 to 10, we'll probably have some indications of medications that are GLP-1s that come in different formulations at different dosages for different indications. But if you need this for any of the FDA-approved indications, you are likely going to need the standard therapeutic FDA doses. I'll hand it over.
Anecdote does not equal evidence.
Yes. Say that again, Dr. Whalen.
Thank you. Anecdote does not equal evidence. So when you see somebody telling a lovely story on Instagram or another social media platform, that is all it is. It's a story. It is not evidence.
Great. And Dr. So your answer was a great segue to the next question I would like everyone maybe to weigh in on is how do GLP-1s impact weight stigma in our society from a public health standpoint to a clinician standpoint?
Well, to be honest, I haven't had to deal with it as much at Sage, but I have had students asking me about it, and it's usually people who are appropriate for it. So I feel like the younger level people, the students that I get to have an insight into, they tend to, the ones I have had asking me have not asked me for any reason that other than, they do have large weight issues. They do have blood sugar issues. They do have all the indicated issues. So I haven't had anyone just come in because they want to be skinnier than they already are. So I may not be a good person to answer that question. And that's partially because, we're heavy-duty health science here, and so students already have some knowledge before they come in a lot of the time. Not always, but a lot of the time. So I may not be the right person. I don't know if you have some insight. Anyone else?
I actually have a bit of a controversial answer to this. If you would have asked me about a year ago, I wholeheartedly would have stood up here and said, GLP-1s are breaking down weight stigma. But I do think, as I talked about in the keynote, I am concerned that we have hit a place where GLP-1s are now being corrupted by corporations, and they are potentially adding to weight stigma. So there is an expectation that everyone on these medications should be thin, that everybody should be thin. And I think we have to push back hard, that we don't end up back in a Kate Moss, heroin chic era of bodies, because bodies do come in different sizes, and health comes in different sizes. And it is a truly remarkable drug that I will die on the hill that GLP-1s are amazing, but society has a way to take beautiful things and to turn them. So we have to be careful.
Yeah, I agree with this, and I think it's a philosophical question, isn't it? Because there's such a tremendous amount of benefit that can come from this medication from people who need it. But there is also tremendous potential for people that might not need it to use it in ways that are not evidence-based. So I think really coming at it from the framework of medical evidence, of getting the care that you're going to get to receive this medication in an environment that is from an MD that you see, that you believe is well trained and utilizing a broad spectrum of therapy, including a nutritionist, including how you look at what you're eating, how you exercise, because these medications make you lose weight, which also includes muscle weight, so that's where protein becomes important. There's so much that has to be considered by this, and the internet is a real difficult thing, because people tend to say, well, I can figure that out myself, and I need it for this, and I'm going to get it for this, and that is that is where the stigma can come in. I think we've come a long way in terms of understanding what stigma is. And in public health, we talk about this not only with weight, but in terms of people with substance use disorders. Shame and stigma just doesn't have a place in proper medical care. And trying to normalize that across the continuum of health is something that everybody should really be invested in, so that this doesn't affect people in how they make the decisions about their bodies. We want to make decisions about our bodies that enable us to be stronger and healthier. So that's what I'd have to say about that.
Yeah, I mean, I definitely agree. It's kind of controversial. I've seen where it's helped weight stigma. I can also see where it can be a little bit detrimental for it too. And I think that's where the interdisciplinary approach comes into a big play of this, ensuring that we're screening patients appropriately and assessing medical history and mental history too, to ensure that we are potentially preventing some of those circumstances where it may not be the most appropriate for the individual. So definitely ensuring that behavioral health is involved, that they're having those consistent follow-ups to really help prevent that.
Well, my colleagues answered that. See, they showed me how to use the microphone, but I already forgot. My colleagues answered that question, I think, beautifully, and the only thing that I would do is really just kind of re-echoing some of these different considerations of looking at the evidence, number one, and number two, as we have articulated and reinforced, it is about the whole patient, and patients still need, at the end of the day, to have that balance in terms of nutrition and their diet and understanding what each of those different foods actually do and how to kind of create that balance. That was a comment that came up from one of our attendees in our morning session of just understanding what should be on the plate. So just understanding what is valuable nutrition and how everything plays a role that is so vital to your overall health as an individual. So just kind of keeping and encouraging the dialogue with patients and reaching out to their clinicians across disciplines in terms of assisting in their overall health and approach.
Yeah. I think that's a perfect way to end our panel session. Thank you so much to all of our panelists. That was amazing. I know there are many questions that were left unanswered. Hopefully you can ask some of them in your breakout sessions. So I'm going to dismiss you now to your breakout sessions. So do we have our helpers again? All right, so thank you for joining us today. We look forward to welcoming you at next year's event for our culinary nutrition session.